looks like we've got a solid number here. Still a few more people jumping on. Again, if you have questions, please type them into the question or the chat box, and I will be glad to address those. I'm sure Raylette and Tracy will have some more interaction for us throughout the presentation. This is day 2 of the HIV webinar. We will send certificates out within the next week. You should receive those. All resources and material from yesterday and today will be posted, and then a survey will be sent out in the morning. You should receive it in your email, so make sure that you complete it. But Raylette and Tracy, I will let you go ahead and take things over to get started.
Thank you so kindly, Amanda. And hello and welcome, everybody. Welcome to part 2 of the HIV STI training webinar. We are so excited to be a part of this webinar again. And once again, here's an overview of what you will get out of this webinar, which is what we went over yesterday. So that is great.
Welcome back, you all. We're so happy to have you here. This is Tracy Johnson, and hopefully, if you're new, if you're new from yesterday, just put in the chat box that you're new, so we know we have some new folks that were a part of it as well. And as this will be very interactive, and excited to have our other colleague on the phone as well.
Yes, Ricardo, say hey to everyone.
Good afternoon, everyone. Thank you for being on the call again, to the new attendees and for those who were on yesterday as well.
Well, you know, we like to keep things engaging and exciting. So what we want to know, if you feel free to please type in the chat box, what type of sexual healing does your community need? Amanda, please, video. So what type of sexual healing does your community need? Think about it. And what do you think we mean by that?
All right, guys, we're going to do our transition over to sharing my screen, so bear with us like we did yesterday.
Thank you so kindly. And do we have any comments in the chat box?
Let's see, it looks like we do. And I want to remind people, I know we'll mention the chat box, the question box. We're keeping an eye on both of those. I know we've got some people that can see chat box, some that can't, but we're keeping an eye on both so that we get your questions. So we have here, Deanna is saying love is love, acceptance, education about STDs. My community needs more education, awareness, especially for the youth on the ways of transmission.
And who wrote that?
That was from Ms. Keela Blakely, who I believe is with Insight.
I love that.
Okay.
Yes.
All
Mhm.
right.
From Mark, we have the normalizing of safe sexual practices would make the community healthier. So a lot of good comments in here.
Awesome. Awesome.
So now let's get into and really talk about sexually transmitted diseases, also known as sexually transmitted infections. Some individuals still use both. And so when we look at and talk about sexually transmitted infections, you have, as you might think, bacterial infections are caused by bacteria and viral infections are caused by viruses. But the most important distinction between bacteria and viruses is that antibiotic drugs usually kill bacteria, but they aren't effective against viruses. So bacteria are single-celled microorganisms that thrive in many different types of environments. Some varieties live in extremes of cold or heat. Others make people in their home intestines where they help digest food. Most bacteria causes no harm to people, but there are exceptions. Infections caused by bacteria include gonorrhea, syphilis, and chlamydia. Now you also have viruses. Viruses are even smaller than bacteria and require living hosts such as people, plants, or animals to multiply. Otherwise, they can't survive. When a virus enters your body, it invades some of your cells and take over cell machinery, redirecting it to produce the viruses. Diseases caused by viruses include herpes, AIDS, and HPV. Okay? So now let's talk about syphilis. So syphilis is caused by a bacteria. Syphilis is curable. You have an incubation between 10 and 90 days. Your average 21 days for a blood test for negative, and it's past direct contact when you have a sore, which is known as a canker sore. So it is transmitted through sexual contact. Once again, there's a sore that it develops. It's called a chancre, and then from mother to baby and giving birth, it is also transmitted that way. So here, the primary stage is associated with one sore called, as I mentioned, the chancre. Okay, it is usually passed during intercourse during that particular stage when that chancre is present, and that represents about 90% of the syphilis cases that result from today. Okay.
And so one of the things that we wanted to make sure you know is that 10% of the syphilis infections, they're definitely caused during the secondary stage. They usually, many of the symptoms are not infections. So it makes it really a more difficult to find treatment for that type of infection. The secondary symptoms will resolve usually without the treatment within about 6 weeks, on average, a month, or for most people.
So when it comes to syphilis and how is syphilis detected, basically you go to the doctor and you get a blood test. And the blood test can tell if someone is testing positive, and it can be cured with antibiotics. However, if there's damage done by syphilis, that part cannot be repaired. And what do you mean by that, Raylette? Well, that's the latent stage that we call a syphilis. So if you have syphilis, it's been in your body, you went through primary and secondary, and you have syphilis that's been in your body, then it remains in your body. And if it's in there for years, it can cause other damage to your organs. It can cause damage to your eyes. It can cause, some folks have been known to go blind behind untreated syphilis gone untreated. So these are some things, so that cannot be curable. However, syphilis itself can be curable. Okay, and so here are some symptoms of syphilis.
And the reason we're giving you these symptoms first and foremost ahead of time, because we think it's really critical as we move into that next phase of talking about how to prevent it, that we definitely felt it'd be best to give you an overview of what some of those symptoms are, some of those areas of STIs.
Yep.
And like the data we had, I'm sorry, Ricardo, go ahead. Did I cut you off?
Yeah, I was just going to say, in addition to the symptoms, as we were focusing on HIV yesterday, it's important that in some of your jurisdictions, it's important to look at your data to say what does the syphilis data says in comparison to HIV, because in many states and jurisdictions, syphilis is a co-infection to HIV. So a lot of times, especially people that come from the focused population, those being Black SGL individuals or who's ever at more higher disproportionately affected by HIV in your jurisdiction, most of them who are reactive for syphilis could also be reactive for living with HIV. So that's also something to keep in mind as well.
That is correct. Thank you, Ricardo.
And I think that what that says is for many of us is that if our communities are really seeing a potential high level of syphilis, we should also be very concerned about the potential rise in HIV.
That is correct. Thank you, Tracy. And speaking of data, let's look at North Carolina's data and see what it says. Now, looking at the current data by gender, men account for the majority of the cases, and there has been an increase from 2014 to 2015, and it's remained steady there in those years. Okay. And this is data as of May 1st, 2019. Now, if we look at it at the age breakdown, 25 to 29-year-old is the highest, followed by 20 to 24 and the 30 to 34-year-old age range. Once again, this is data as of May 1st, 2019.
Which gives you all an understanding of ideas in terms of how the state looks at the data and how we see the data for our state here in North Carolina.
Now, when we look at the data and break it down even further, here you see African Americans account for more than 50% of the cases, followed by Caucasians as of May 1st, 2019. Wow.
And notice that continued rise that we begin to see in the data of both those populations, which means is that if we're going to be very preventive in nature, we really have got to impact this data as well as the other related data that goes along with this.
Yeah. Awesome. So now let's look at gonorrhea. Gonorrhea, once again, is caused by a bacteria. It is an incubation period of 1 to 30 days. The person can pass it on even without symptoms. And yes, gonorrhea is curable. And here's your modes of transmission. We got sexual contact, penis to vagina, penis to anus, oral genital, birth, mother to baby. So here are some symptoms in the male that you may see. Okay, we get the discharge. They'll have the burning during urination. And here are some of the complications in males.
And what you see here is that their signs and symptoms may include, a burning sensation when urinating, a white, yellow, or greenish discharge from the opening of the penis. Also, you sometimes will see, sometimes in men with gonorrhea, you'll get a painful or swollen testicles as well. And also a small number of men may be infected for several months without showing symptoms.
So look at the gonorrhea symptoms for females. They will have that painful urination, You may have some abnormal bleeding, pain during sex, but a lot of times it's asymptomatic. They may not have any symptoms at all. So the complications in females, what's known as PID, which is a pelvic inflammatory disease. So what that means is the insides of a woman, there's an infection there. The infection is in the uterus, the fallopian tubes, and it can even travel within the organs, which cause a woman severe pain. A lot of times when a woman is diagnosed with PID, we tend to hospitalize them. Okay? So look at the gonorrhea cases right now in North Carolina. And look at this slide here. As you can see, in 2018,
the year has continued to rise and continue to go up. We also notice, with specific interest, is that the women increase has continued to be steady and going up as well, but the men have drastically went up quite a bit just over the last 3 or 4 years of the data that's shown here from 2015 to 2018.
And so roughly the females is ahead roughly about 600 in this diagram here. So next one, looking at the age range breakdown in the cases of North Carolina, 20 to 24 is the highest. However, look at that 15 to 19 age range, especially with the young ladies.
So what we need to, one of the things that I'm hoping you all are thinking about it, if you want to just put in a chat what your thoughts are as you sort of look at that cluster early on. Clearly, it shows some unique data of the cluster of ages of men and women at a certain point in life and stages in life.
And also, what that tells me is they're having unprotected sex. Because your STI rates are high, which means unprotected sex. And then look at this one here. Once again, the breakdown, you have African Americans is once again leading in the cases, followed by, interesting here, unknown. So here, they didn't specify. It's listed as unknown, which folks have that right. So that's the second highest, followed by that. But once again, now I want you to look at your county. And once again, the dark purple areas is the highest need for the gonorrhea rate in North Carolina as of May 1st, 2019. What are your thoughts? Please chat in the chat box. What are some of your thoughts, especially those of you who are on the call participating and you see that dark purple and you're like, I'm in that county. What are some of your thoughts when you see that?
And tell us what county that is. And for those of you on the call yesterday and seeing this map as it relates to HIV, you may see a correlation, or you may not, which is also should tell you a story as well about what you might need to do as it relates to STI and HIV.
Anything in the chat box, Miss Amanda?
Not yet. Not yet. I'm keeping an eye on it though.
Okay, awesome.
Here we go. So rural counties, there's less access to care, less information about risk. Cumberland County has a high rate. They clearly need to change some prevention education, I guess, around this topic. Let's see. I have a question here in regards to how is our sex education courses in the high school to discuss safe sex practices? What do those look like? Gonorrhea has increased in Gaston County and exceeds the North Carolina rates. Stigma associated with the, let's see, I'm sorry, it's cutting off here. Let's see. Okay, I think it cut off right there for a second, but it may be a lag in what's coming through.
Yeah, but I'm very particular talking about there's very little sex education in our community. That one comment that in the schools and stuff, and so that was that's a lot of comments that you see come across.
Yes, and then we talk about the schools. Also, what about the sex education within our community programs, within the prevention programs? You know, the after-school programs that do prevention that youth are a part of when it comes to the HIV prevention programs. I tell folks, you can't do HIV prevention without doing STI prevention. They go hand in hand.
That's
and
right.
So that's a great point. And so if we look at it that way, especially for those who are running HIV prevention programs, if you do not have STIs incorporated, please incorporate STIs into that, because bottom line, it's unprotected sex.
And another area that I think that we found in some of our trainings that we've done nationally, and I'm sure Ricardo may have some additional insight to this, but, you know, we know that at a very young age, you know, family participation and conversation with the young folks in a way that's beneficial for their families and the way they do it is critical. Although we know in the perfect world, abstinence is a great way to teach. You know, we also know that families play a very important role in that process.
Yes,
yes, and I'll add to that in saying, as Tracy mentioned, families play a huge role. Stigma is really important to addressing your jurisdiction, and part of the stigma is knowing what is it that people have ambivalence around. What are their thoughts around the norms of sex? As we look at these numbers, it's clear that people aren't using condoms. And so as we look at what does that mean for families to use condoms, what are their thoughts? And I always refer to this as heteronormative living, right? So one of the things that came out of a focus group here in Wisconsin is that people said, well, we don't use condoms because when we have sex, we're having sex to have kids. And so some of that norm can actually transition into the parenting and the thoughts and behaviors of others around
I
them.
had a burst of things that came through here on the question box, so we must have had a lag here. Maceo had a question about what are your thoughts on the messaging to those African American males who still believe it's not manly to use condoms. Also, their beliefs may be impacting their message to their children, grandchildren. So a lot of response here that's coming through.
But you know, from my vantage point, and I'll let my colleagues as well jump in. But my thoughts around that population, that group of young folks. I mean, critically, there has to be multiple methodologies of messages, and it has to be early. It has to be at the point, especially when that age of adolescence steps in, and that that's culturally appropriate and culturally inclusive, so they know what this can do to them. And many times, my colleagues and I, like Raylette, has done these trainings, and normally the actual presentation you would have got has a lot more pictures in it to sort of get them to think about the impact of what that means and what it does mean. And I think that's critical. And I think using different modalities in those populations, like different mentors, different groups in their like barbershops, using things like that to have that conversation is really critical. And the more we can encourage and engage those non-traditional, if you will, settings in African American communities early on, the more effective that we can be.
And I will add to that, I used to run a nonprofit. I'm a nurse by trade, but I used to run a nonprofit in Los Angeles, California, Prototypes Keeping It Real. I was a Minority AIDS Initiative grantee, cohort 1 and 2 under SAMHSA, which is Substance Abuse Mental Health Service Administration. I had a program that was in 2 different housing projects, one in Los Angeles, one in Watts, California. Also had a program at a St. Mary's High School Academy for all girls, as well as an outpatient substance abuse treatment program for women who also had an HIV and AIDS diagnosis. We incorporated a prevention program within that. So I had multiple offices, locations, but in working with the African American population, especially the very high risk, I was in high risk communities, I used multiple strategies, such as We had prevention curriculums, and incorporated into the curriculums, we used the scare tactics as well. On top of the scare tactics, we also brought in guest speakers who were affected by it, and at the end they would disclose, and the kids would get ooh and ah. So there was multiple strategies used, but I also had, because my targeted audience was youth and young adults, I had a advisory board, and I met with them, and they incorporated their ideas and what worked, and that was incorporated into the program, which led to high success and behavior change within the population I was serving. And so my data was great as a result of me incorporating the targeted population. So those were multiple strategies used on top of environmental strategies, utilizing social media. So utilizing all of those methods, which is what worked in those particular communities, that's how we were able to change the data, and they were able to wrap it up.
I would add, in addition to echoing everything that they both have said, I think it's important to understand that what works for one community or person doesn't work for all. And so we have to have a holistic and comprehensive approach to engaging key populations. I think that, you know, there's a methodology of social media, I think education, I think, you know, even creating spaces where people can come and unpack. Why don't you like using condoms? Can you tell me what are your challenges with using a condom? A lot of times, from my experience of working in prevention, actually frontline staff as a tester, and I did sex work street outreach where I went out and tested women of trans experience who were sex workers. A lot of times using a condom wasn't an option due to the amount of money that they would make. And so some of this is education, but a lot of this is meeting the clients where they're at and looking at those tools in the toolbox to see where we can meet them. Maybe using a condom isn't an option, but maybe reducing the number of partners you have is an option, you know, so kind of going through those steps in education. I also add for youth that there's a good education curriculum that is in most public schools, and it's called Making Proud Choices, and also Street Smart, which is a youth sexual health education curriculum as well. So that's also accessible to people who can access that online.
Thank you, Ricardo. Across the board, I see a common theme of education, communication, and stigma. So I think you guys did a good job of addressing that. And Maceo, who asked that question, said he liked what he was hearing. So thank you guys for responding.
Thank you for participating. Now let's look at this slide here. Wow. This slide represents those who have tested, you know, and at the time of testing, and this is what Ricardo was talking about earlier. Here it is gonorrhea with HIV. And by race, once again, African American population is extremely high. So this slide is a representation of co-infection of gonorrhea and HIV together. This is exactly what Ricardo had mentioned earlier. So here's a slide of the data that represents that in North Carolina.
And if you notice, you notice some steady data increases or on the data, although it's still relatively high for a particular population as it relates to the people of African American descent.
Okay. So now let's talk about chlamydia. Chlamydia, once again, is a bacteria. It's curable, and it can be passed on with or without symptoms. And chlamydia, this one is the one where women, you really don't have too many symptoms. How do you get syphilis? Once again, oral genital, penis to vagina, penis to anus, and birth to mother. And believe it or not, a lot of times when I was nursing, you see that transmission a lot. I've seen it quite often when I was doing direct patient care, even with, especially with herpes. You see that passed on from mother to child at birth. So here's some symptoms for some men as it relates to chlamydia. They will have a discharge from the penis, and that discharge, it'll be runny and whitish, and they will have some burning during urination. So for women, you'll have abnormal vaginal discharge, and you will also have pain during sex. And here's some complications that you may have for men and women when it comes to chlamydia. Okay. And once again, the gonorrhea and chlamydia, as you can see, they have similar complications. So when you look at this slide right here, once again, here's the North Carolina data. Women make up majority of the chlamydia cases in 2018. Now, I don't know if you all picked up looking at this slide. Throughout North Carolina, looking at all the data we have looked at thus far, starting from yesterday to today, men has tend to been higher rates than women. You know, however, here when it comes to chlamydia, women outnumber the men when it comes to the cases of chlamydia, STIs, as it relates to North Carolina.
In that last slide, we thought we started to see a flattening out around 2015, but all of a sudden it started to peak up and started to go up some more. So there are some preventive measures that we have to do in our state here in North Carolina to really impact that data.
So here's the distribution by age. 20 to 24 is once again high. However, look at the 15 to 19. Wow. Look at the young ladies. Those are teenagers. And those numbers are pretty high. So that tells you the work that needs to be done, especially in high school, around STIs. Now, the largest population here is the unknown, followed by African Americans and then your Caucasians, looking at the data for chlamydia cases in North Carolina. Now, once again, look at your county. Wow. So you all have seen this again. Now, looking at the chlamydia in your county, you see the highest rates are the dark purple, and this is the data as of May 1st, 2019 for North Carolina. You all may see some similarities. Anything in the chat box, Miss Amanda?
No, not right now.
Okay.
And I wanted to actually add something to, as you've been sharing a lot of the data for North Carolina in the jurisdiction, and something that I don't hear a lot of people talk about is, to me, I recognize a lot of disparities, a lot of racial disparities amongst men and women. And so what that should do is drive your strategic planning and focusing on these key populations disproportionately affected by not just HIV, but other STIs and STDs. And as we mentioned yesterday, for those of you who were on the call or weren't on the call, it's important to engage those key and focused populations, but also the surrounding populations as well, because what you don't want to happen is you put all your eggs in a basket, but then other populations suffer, and then they end up being disproportionately affected by STIs, STDs, or HIV as well.
Really,
Yes,
oh, go ahead. I'm sorry.
No, go ahead, Amanda.
I did have a question that came through wanting to know if this data included females that have been victims of sexual assault and abuse.
So as someone,
that is a great question. Normally when STIs and HIV is reported, it is reported, so those numbers should be reflected within this data. It's not broken down specific to break it down. There's other searches that you're able to do to where you can find that particular data, but it should be reflective and incorporated in these numbers, but it'll just say the women and the age. I didn't put that data in.
But for comparative purposes, I would recommend to you all, as you look at this data, obviously if that's reported to our state level folks that is coming from the county, and particularly the county health departments, you could actually go to your local county health department and actually help peel back some of that data to try to get that kind of information as well. So that may be a good, quick source to utilize for your efforts.
Mm-hmm.
And in addition to what Tracy just said, if they don't have that information, it's also good to advocate to see why that information is needed. And then for those of you who are at your own organizations or healthcare clinic or community-based organizations, if you do provide testing and you provide testing and other prevention services, that's another thing that you guys can implement in your clinic to actually find that data to use that as support as well.
Yes, thank you. And so what you all are doing and the work is so important. So now, looking at your data in North Carolina, we looked at the HIV data, we looked at the gonorrhea data, the syphilis data, and we've looked at the chlamydia data. So you now kind of have a snapshot of North Carolina and its counties and looking at the data on where it's going. So it's like, what can we do? How our youth and young adults we see they're having unprotected sex. So how do we fix this problem? Amanda, the next video.
All right, give me just a second as I switch back to the screens. We appreciate you guys being so patient with us as we do this.
And we definitely want to make sure that, as you look at this video, that you think about the impacts of sex education and prevention information in your communities, in your school settings, in your whatever settings you have.
At the top, Amanda, make it bigger.
Top right.
Top right.
All right, it is full screen on my end.
Okay, thank you.
Yep.
So please type in the chat box. What are some of the strategies? What has worked in your community? How have you been able to help, even in some of the counties where the rates are low? Maybe you've done some things or some strategies that have fixed the problem in your county. And if so, share with everybody.
All right, I'm keeping an eye on the boxes. People type in. Hopefully, I had a note here from someone that they had to call back in and it gave a busy signal. So if you're having that issue or you had that issue, send me an email. That way we know. I know GoToWebinar and Zoom has probably met their match with capacity this week. They're probably trying to make changes on their end and adjustments. But if you can let us know if you've had that issue, that would be great. Let's see, from Aileen, she has here to join other vendors when it comes to community resources.
I like that, Aileen.
Yes.
That's right. Capacity.
Yes.
Once again, a lot of times folks tend to work in silos. And that's right. You've joined, connected with resources to make that ultimate change within your community and what works for your community. Awesome.
I
Thanks,
don't have
Eileen.
any others, but that's a good one. So I will,
Awesome.
okay, let's see. We can start by addressing sex in a less this is a mouthful, heteronormative view, acknowledging those who like the opposite and same sex.
Yeah.
Now, networking and finding
Yes.
resources for our clients.
Yes, I like that.
So some
Yes,
good
I love it.
responses. Thank you, guys.
Yes. So actually, that's going to take us into our next section, that understanding that people have different likes than what the normative is, and sometimes we may have to do some of that research and support for our clients. And so I thought that it was very important. We, as a team, thought it was very important to really bring both days together. And at the end of the day, a lot of people have made comments about how do we change this? How do we, lower our numbers? And that all sums up risk reduction. So in your communities or in your own terms, what does risk reduction means to you? So if you could just type that in the chat box, and Amanda will let us know, what does risk reduction mean to you? And please define that in your own terms. And Amanda, if you could let us know if people are typing in at all.
Sure. I'm keeping an eye on it. Finding ways to reduce transmission rates from Jennifer.
Okay, yep.
Yeah, risk reduction, trying to limit exposure if you are infected, helping individuals to self-assess the risk and adjust their behaviors.
Nice.
Mm-hmm. Nice.
Nice.
Yep.
Let's see, create an environment with enough protective factors that limit the impact of risk factors and or remove the risk factors.
Yes, I love that.
Yeah. I love it.
Yes.
Participation.
Nice.
What did you say, Amanda?
I was thanking the attendees for their participation. It always,
Yes.
It's helpful to you guys, but it makes these much more enjoyable, the webinars, when people participate. So I'm just thanking them.
Yes.
Yes.
And so I think that that's a lot of great responses for us to move on to the next slide. So, risk reduction as defined, the goal of risk reduction is to help patients decrease their risk to themselves and others, thereby decreasing the number of new HIV infections or whatever your focus is, and in general terms, reducing the number of sexual partners. So a lot of you who gave a response, thank you for that, because all of that aligns right with what I just mentioned to risk reduction defined. So today we've heard a lot about STIs and STDs, and yesterday we heard a lot about HIV. And the key factor in achieving risk reduction is education, education, education. As I mentioned earlier about racial disparities, health literacy in reference to clients and in the healthcare setting shows that the average African American reads at a 6th grade level. And so as we are educating people and we're giving them documents, it's so important to understand that the language has to align, and that we have to, as educators and healthcare providers, whether that's in a nonprofit or clinical setting, we have to gain those skills to be able to educate and make sure that clients understand what is being communicated so that they can apply that to their overall sexual health. I often make the comment that we just don't want people to get an HIV test, but we really want them to move in the needle of valuing their overall sexual health. And so as we looked at some of the data in your jurisdiction, I wanted to put a slide up for STD data nationally. And if we look at this, we are most definitely seeing a high rise in STIs and STDs around the United States. Specifically, young people ages 15 to 24, Black or SGL men in general. And as we also look at the numbers, chlamydia has 1.8 million cases of chlamydia and 19% rate increase since 2014. So we are constantly seeing these numbers rising. So then that means that there's a lot of work that we need to do into strengthening our toolbox. So what can we do? What's in our toolbox? Risk reduction counseling. In many nonprofit settings here in Wisconsin, there's a counseling that's done prior to the test. And that counseling is not just to collect data, but to really assess where the client is. And so some recommendations are risk reduction counseling, motivational interviewing that goes under that. Meeting the client where they are. Stages of change, we'll go through that. Routine testing and 3-site testing. It's important that if someone is continuously engaging in sexual activity that puts them at risk, that we make sure that they can come and get tested for HIV every 3 months and get their STI and STD testing. And then also condom distribution. We push for condoms, but how many of us have actually asked people, do you know how to properly and effectively use a condom? So motivational interviewing is something that we here in Wisconsin have implemented for people who are funded by the HIV program. And motivational interviewing is a collaborative, goal-oriented style communication that with a particular attention to language of change. It is designed to strengthen personal motivation for and commitment to the specific goal by eliciting and exploring the person's own reason. So it's really about gaining the language and the skills to encourage people to actually make change in a goal-oriented way, besides just saying, use a condom and stop having sex. So some things you can pull them all up, Brillette. So one of the parts of motivational interviewing process is this 4-step process. I think it's important to really understand what this is. And the first one is engaging. It is a collaborative conversation. A lot of times people talk at clients instead of engaging them. And so it's important to really engage them in a way that focuses in on the why they're engaging the way they are, and then evoking to really dig deeper to get under some of the things that they're talking about. And then there you can actually do some planning to really help implement some effective changes that could actually help them. Motivational interviewing methods. Ask, tell, listen. So when you're asking, it's using, permission, open question, and closed questions. Actually knowing the difference between the three to really get it what it is that you need to get. So an example may be, what do you know about using condoms? Instead of saying, can you use a condom? They may say yes. What do you know about using condoms? Tell, to inform, give feedback, to advise. Actually using that to say, using a condom this way will benefit you because it is more effective. The listening, again, motivational interviewing is about a collaborative effort. And so showing that appreciate, reflecting, and summarizing. I think that a lot of times, a lot of clients that I've seen in the past, they don't know their full self-worth. And so any little step of change that they can make is worth acknowledging. Wow, that is amazing. You have gone from having 10 partners in 1 month to 5. Let's keep going and let's see where that goes. And the 4 key principles of MI is partnership, acceptance, location, and compassion. Not only do we want to meet the clients where they are, but we also want them to know that they matter. And so we don't want to judge them, and we want to create the space, as many of you have said, for them to feel accepted. And we want to evoke those thoughts out of them so that they have a safe space where they can unpack and really build on some of their strengths. And when we do so, we want to lead with compassion. They are still human beings, and we're not here to save them. We're here to give them the skills and tools that they need to live a better life for themselves as they best see fit. And so with that, as I talked about meeting the clients where they at, this is a model that I often use for grantees when talking to them about meeting clients where they at. It's called the stages of change, and some of you may or may not know about this model. But the model shows us as you enter the wheel, you have pre-contemplation. Pre-contemplation is, I really don't know, I really don't care, I have no interest in knowing that. And so you can use MI to really evoke some of that. Tell me why that is not important to you. And so then as the wheel moves, we move to contemplation. Contemplation is, okay, I kind of know how to use a condom, but I really don't, okay, I'm not ready to use a condom yet. And then the wheel moves into determination. I'm ready to use a condom. I'm going to practice using it. We'll see how it goes. And then you have action where I know how to use a condom. I know how to use it effectively. I've been using it for 3 to 6 months now. And then the wheel also goes into maintenance, which is that ongoing cycle. I have been using a condom now for 6 months to a year. Every partner I have, we use condoms and have conversations. What's interesting and what's important to know about this wheel and stages of change is that a person can relapse at any moment. Someone can be in contemplation where they know about using condoms and they could be ready, but then they might end up not using a condom. Or someone can be in action for 3 months where they're using condoms for 3 months and then all of a sudden they don't use a condom. And so understanding that every person will be different. Amanda, are there any questions put in the box yet?
No questions. I do have a comment here that they really like that you're using the motivational interviewing approach to meet people where they are.
Yes, and it's interesting, and I'll just say this quickly. When SAMHSA and the CDC started funding testing, CTR, client testing referral, is meant to be a 20-minute session. It's not meant to really be what I would say, a full session of addressing all of these things. But one of the things that I have challenged grantees to do is that, we have to meet the clients where they are. And sometimes 20 minutes is not enough time to do that. Or the client might not be ready to get a test. Most people, when they come to get tested, at least the data from Wisconsin has shown, is that when people come and get tested, it's probably too late. When people come and get tested, they come because they've had symptoms or someone has told them that they've been exposed. And so that's why sexual health is very important, but we can't get to that place if we don't build that engaging and have that compassion with the clients. And so also with that routine testing, if a person is going to still engage in that activity or they're from that focused population, getting tested every 3 months is very important. And it's important to explain to them why and maybe inquire about why they think getting tested every 3 months is important. This is all depending on the risk and exposure. And the client may need other services. It might not just be HIV or STI or STDs. It may be Hep C, it may be other vaccinations that a client may need. So this speaks to having that holistic approach when working with clients if you have the capacity to do so. And if you don't have the capacity to do so, as we talk about that partnership and collaboration, doing external referrals really helps. And I also will speak to referrals as peer-to-peer referrals. So if I worked at Planned Parenthood and Tracy worked at the local hospital, if I'm going to send someone there, I may call Tracy directly and say, hey, Tracy, I'm sending over John Doe who's interested in receiving some of your services. That puts comfort into the client, and it actually, from research here in Wisconsin at least, people felt belonged. They felt like they were more than just a test and that they were moving to feel valued as a person.
They didn't feel dropped at all, that they felt connected, right?
Yes, they felt connected and engaged. And another comment that I'll make is that when we look at the populations that are disproportionately affected by HIV and STDs, this translates into their everyday lives. Some of these people, they don't know what self-worth looks like because no one has shown them. And if someone's shown them, it didn't look like this. And so sometimes we have to motivate and evoke and encourage people to be a better version of themselves. And I think the data reflects that. I always say that STIs, STDs, and HIV is a symptom of something deeper, and that can be mental health or other social determinants of health as well, as we spoke about yesterday.
That is correct. And as I, tell, participants who've attended a lot of our trainings, a lot of the trainings we've done for SAMHSA, a lot of times we look at treatment in the field of treatment, such as substance abuse treatment. You have more comprehensive services, but when it comes to prevention, the services tend not to be so comprehensive.
Mm-hmm.
So, what makes programs successful when it comes to prevention providers? Well, you have to provide comprehensive services. Every participant had a chart. They had a file, whatever you want to call it. Everyone had an intake in order to determine what's the baseline data so we can meet them where they are at. And in the intake that I developed, incorporated in that intake was a Rosenberg self-esteem scale, a CESD-8 scale. Those are screenings for mental health and an assessment. So if someone is displaying some trauma, some stress, etc., that was a referral to the therapist. I had a part-time therapist on staff. Why? I knew I was working with some of the highest risk populations in Los Angeles. So, and then once the intake was done, there was a case conference. We met as a team, the case manager, the peer support person, every staff, the therapist, the team came together. Who's the right fit for this particular client? Who's the right case manager? Who's the right peer support person, etc. But then everyone had a plan. Just like in treatment, there's a treatment plan. Well, in prevention, there's a prevention plan. So they know what are they coming to see? When are they going to see case manager? When are they going to see peer support, etc. It's customized for that individual. So the services are comprehensive. So we don't drop the ball, but yet we're able to keep track. So that way, when I dealt with STIs, I can make sure they're getting the proper medical care. If there's a housing issue, whatever the risk factors identified within that individual to overall have behavior change.
Yes.
So it's those comprehensive services.
Yes, thank you for that, Rilla. And what I will say here in Wisconsin, I lead a number of initiatives around prevention, and that is inclusive of care in people who are at risk for HIV. And two things that I want to share with you. During the focus group, what we discovered around comprehensive testing is that here in Wisconsin, we do an amazing job at offering comprehensive care services. People who are living with HIV, we have a separate funding stream, Ryan White dollars at ADAP, for people to receive different medicines, but not just medicines for people living with HIV, but insulin, other drugs that they may need to live their lives. We have mental health services. We have a housing fund for people who are trying to move. We have legal services. And what the focus group showed us was that we need to move that needle for all populations as well. And two things came out of that to let us know that not only do we need comprehensive services, but as we talk about meeting clients where they at, we also have to look at the internal piece within our organization, which is structural determinants. It's really having leadership that reflects the population, people who don't reflect the population, them understanding what it is to have biases and what those biases do and how that impacts a population. We had a participant share that in another state, when they were diagnosed with HIV, they were just getting their results and they were given nothing else. And they were out of care for 6 months. Those things should not be happening if we're meeting clients where they're at and we're giving comprehensive services. And so those are just some things to think about as well.
You are so right, Ricardo.
Mm-hmm.
And just one more thing, the work that you all are doing is so important. I'll share one quick with you. When I was nursing and doing direct patient care, had a young lady who was coming in. She was HIV positive at the age of 14 years old, and she kept going out, spreading it on purpose, and we couldn't figure out why. And the reason we knew this because every month, every other month, she was coming in with a different sexually transmitted infection. So finally, I get frustrated as a nurse. I'm going in to talk to this 14-year-old young African-American young lady, and, and I'm having a heart-to-heart. What is the problem? Why are you doing this? Legally, the medical staff, even though it's a felony, we cannot report her. We would lose our nursing license. So we couldn't report her, but yet going in to have a heart-to-heart talk to her, the first time she had sex, she caught HIV. She caught an HIV diagnosis, and she was so angry that she wanted to spread it to as many as people as she can. She didn't care. She felt she had a death diagnosis, and so as a result of that, it went on and on. We ended up connecting her to a nonprofit. And so the work that you do is so important because it was a community-based organization that was able to change her behavior to where she would use protection, to where she was no longer coming in every month, every other month with a different STI, along with us knowing as her medical provider she had this HIV diagnosis. And so it is just so important. So I just wanted to share that story, that the work that is done in the community is so important. So relationships with the medical staff, hospital, clinics, and that's why that community health worker role as well is so important. There's a liaison between the medical provider and the nonprofit to where that's information with the proper consent can be shared to where you can get that outcomes and that change in your community. Ricardo?
Yes, thank you so much for that. So we've talked a lot about condoms, and often when we talk about STDs and HIV and when we speak about prevention, we say condoms, condoms, condoms. And as I mentioned earlier, how many of us have actually asked our clients, can they demonstrate how to use a condom? What are the stigmas around condom usage, and does the brand matter? Below, I have a link that Amanda's going to send out to everyone, which you can look at to actually show a video in your settings and however you want to, that really shows someone how to use a condom. When I do CTR training, I actually use this video, but I first walk through with the clinical providers on having them show me how to effectively use a condom. And I'll tell you, you'll be surprised at how many people who are providing these care services cannot effectively use a condom. And so that's important because people think they know how to use a condom, but the data shows that either people aren't using a condom or they can't use a condom. Yes, and I will also send out, if there's a video for motivational interviewing, it's a 17-minute video on YouTube. I will also send that stuff out as well for you guys to add to your toolbox. And so as I talked about those recommendations for you today, remember your prevention toolbox. Remember the things you have in your toolbox to really be effective. And something that I didn't add to this is your network, your collaborators, your community leaders. We can't do this work on our own. Who in our communities can we engage and educate and build that turf and that trust to allow them to disseminate this information for us and or speak on your leadership on your behalf to engage and bring people in? So I thank you guys for listening to me during this part, and I hope that you guys have learned something. And if you have any questions or feedback, please offer that. And we are closing this out. Rayla, you want to take over?
Yes, thank you, Ricardo. Now, also, before Tracy Johnson take over, just think about it and begin to write in the chat box. Begin to chat. What question do you have that we may answer around the work that you're doing? So we can personalize this. So any questions that you may have, any strategies, anything you may want to ask us, please put that in the chat box as Tracy Johnson begins to go over environmental strategies. Mr. Johnson.
Yes, I want to leave you all with a critical piece. You've heard a lot today, particularly these last slides with Raylette and Ricardo, as we focused on how to impact what we call direct prevention programs, using direct service directly to the individual. But we also know, just like any other strategies that we've made massive and in substantive effective change, we've also used what we would call environmental strategies. And I want to leave you with what we call the CAMP model, the CAMP model. And we call it that because it takes the indirect strategies that Ricardo mentioned at the last slide, and how getting key leaders involved, getting key folks involved beyond just not only doing the direct service to the client, but also impacting the broader population. And so that CAMP model is C. We got to focus in on our community norms. If you can impact the community norms in a way that multiple folks are seeing this as an important strategy of dealing with STIs and STDs in your community, and building the norms up of why it's not a good thing to have, and how do we make that change with our young folks, particularly with the data, that's really important. The next thing is access and availability. That access and availability is so critical that as we talked about, the ability to make sure that there is condom availability and access to it is not behind somewhere where you can't get it. The more availability of information and education services that really impact our folks is really important. So not only do you have to deal with community norms from an indirect way, but you also have to from indirect prevention way. But we also want to deal with access and availability. The other part of CAMP model is what we call the M model, the M piece, and that's media and marketing and communication. Media and marketing and communication strategies that impact our broader population really help change or reinforce the community norms. And if we're going to really impact the population of the direct service work that we just talked about, you really want to make sure that you have a strong impact on media and communication. And then the other pieces that we want to lead, and that includes things like social media, media literacy, media advocacy, social marketing campaigns, using all type of social media tools as a critical way of doing it. And then the last piece is the P of the CAMP model, and that is policies and ways that we can make sure that the availability of things that are available through policy, that you can have health departments having opportunities of having condoms available. You can have methods where schools can maybe want to talk about sex education and having more engaging to that certain population. So we know policies are really important in the process of this effort. I think if you think about the CAMP model, I want you to think about other models that we've seen substantive change, behavior change in, that we do every day. One of the things that we do, if COVID-19 wasn't around and we were able to get into our cars, the first thing we would do is we would put on our seatbelt. Imagine how behavior change has really happened with seatbelts, and how individually they impacted us and how we can make change. But collectively, as a group, they really changed the community norms. They made it. The cars now have access and availability of seatbelts, and sometimes you can't even move a car without having something come on or a noise that gets annoying. So we've seen changes to where we have behavior change like that, and we reduce the numbers of folks who have fatally been injured in their traffic accidents. So another indirect model that we can see behavior change is smoking. Obviously, we've seen that change where we impacted the actual individual so him or her can stop reducing their smoking issues. But we've also built a sort of a broader piece and did policy change and media pieces of the CAMP model to really help individuals make substantive change there. So I wanted to make sure you all know that doing the direct piece is just as important, but also doing the indirect environmental strategies approach, using that CAMP model, community norms, A, access and availability, M, media and marketing, and P, policy, is critical areas that you can also do and have impact on STIs and STDs in the community.
Thank you, Tracy, for that. Miss Amanda, anything in the chat box?
I do have a couple things that are coming through. The first one.
Of them.
I'm sorry?
I said, okay, let's go ahead and start with one of them.
Yeah. We have a question here wanting to know if you have something like an STD Jeopardy game or other type of fun activities for youth to engage them to make learning and talking about this topic a little bit more enjoyable.
Actually, we have a Jeopardy game that we have been doing for years, where there's all questions geared towards STIs, HIV, as well as substance use, the connection between using a substance and how your risk factor, your behaviors change that puts you vulnerable for STIs. So yes, we do have that information. We can send that electronically. But there's also an actual game that folks use where they purchase equipment. We've seen it really, really high tech.
Yeah, we've seen it done. You can actually do that, and you can actually put it in it, and you can custom make it because your community may have different STI concerns and issues. So you might want to make it where you can customize it for your own county or city.
Thank you. And if you guys send me those resources, this is something that we can get out to those who are attending today with the information that Ricardo is going to send us as well. Sage here has a comment that she's thankful for the references to the youth and adolescents, and that she agrees that talking and keeping it real with young people is probably the most impactful strategy with them. In their community, they have a Just Teens clinic, which is strictly
nice.
and focuses on sexual health with teens. She says that she questions what is happening with seniors, understanding that the data shows that STDs have increased among that population.
That's true.
Yes, that's true. I remember several years ago when the seniors' rates for HIV were actually on the rise as well. Seniors in nursing homes, they were multiple partners and they were engaged in a lot of sexual activity, so that is true and that is correct. And that Just Teen Clinic, that sounds amazing. Can you type in the chat box, part of that Just Teen Clinic, do they have some type of a teen advisory or a teen youth group? I love that.
Yeah, I'll keep an eye for a response there for that.
And what else do you have?
Yeah, that we have some awesome ideas. Mana here, she notes for an environmental strategy, condoms should be free or very low cost, not just at clinics with limited hours that require thinking ahead in order to access, but at every place that currently sells them. So pharmacies, Walmart, gas stations.
That is so correct. And actually, check with your local public health department, because a lot of times they have condoms that are free because they pay for them in the job and their role is to get them out to the communities. And so if you're with a community or faith-based organization, you're able to put the condoms in certain places within the community for permission where they're free. I know we used to give out condoms. The kids would know if they came to our organization and received a mini manila envelope, we would shove condoms in them. So they just come and go in the drawer and to pick up a pack, and there'd be like 6 condoms in there. And then there were some that were distributed throughout certain restrooms and other locations. So you are so right. But if your health department have them and they're free to you as a community-based organization, obtain them, set up, ask the youth where you can put them at, and see, where it's feasible, and put them out there. Great question. Great comment.
I don't have a response yet on the teen clinic that was mentioned, so I'm waiting on that. But I know we've got a lot of participants today, but if I would like to open up, if anyone wants to talk or they want me to unmute them, I'll be glad to do that at this point.
Please, we would love a conversation with some participants.
Yes.
We would love
I don't want to unmute everyone at the same time, but if you have something that you want to talk about, please send me a note and I'll be glad to do that. I do have a response here from Sage. The health department here in High Point established that clinic about 3 years ago. She's not aware of the teen advisory component. but he believes that's a powerful suggestion. So.
Awesome. Well, Sage, I just love that teen clinic. I mean, that's great for even others to hear. It's like a safe place for them.
Yes. Yes.
Anyone would like to unmute it and share?
Yeah, I don't have anyone that's responded yet that they would. In the meantime, Mina, in response to the comment she had earlier about the access to the condoms, she did note that the same way that we use access and price to prevent folks from alcohol and tobacco use, we should be doing the opposite and decrease prices and increase access for things like that.
And let me also say that one great example of what I talked about with the environmental strategy approaches is what we're doing with COVID-19 right now. How we're doing individual information so people can make individual interventions and engagements in preventing it, but also we're doing that using that community norm, access and availability, that whole camp model, media marketing to really make substantive change around that as well. So, you know, when I talked about camp can be used in all aspects in public health, just like it can be used for STIs and STDs. Definitely is being used right now with our own realistic terms right now with COVID-19.
Right, thank you. I don't have anyone that's typed anything else or requested that we take them off mute, but I'm keeping an eye on that. If you guys need to move forward, feel free.
So we are at our last slide here. Any questions, observations, or takeaways? If anything, there's anything else you would like to add, any other resources you may need, questions, please feel free before we end the webinar. And once again, we applaud you and continue the great work that you all are doing in your communities.
Before we move forward, I would like to ask Tracy for suggestions on how prevention, like block grant folks, can integrate this type of information into the work that they're doing now.
You're asking me that?
Yes.
Okay. How prevention folks can integrate this work into block grants?
Into the work that they're doing now. How can they integrate this type of information into what they're already doing? Do you have any?
I think one of the things is that we know that you know, effective information around public health issues like STI and STD is all part of good prevention and prevention. I tell people all the time, prevention is prevention is prevention. And so as you impact your block grant that comes along in substance abuse prevention models, when you're doing good prevention, use that model to impact all areas of concern. Use it for violence prevention. Use it for STI, sexual health prevention. Use it for substance abuse prevention. Use it for the model can be utilized. Just incorporate the key components that you're doing. And if you have folks who are there, who are, you know, when you have adolescents who are there to talk about misuse of substances, you mentioned misuse of substances as well as other areas like STIs, STDs, and so on. That's how you can incorporate it away. Because most of your substance abuse block grant dollars are focused on just substance abuse, but we know there are other risk factors engaged in this process. And so as you do good prevention, both direct service and indirect service using environmental strategies, always use words like such as, including. So then you can add on the other preventive areas that you need to focus in on as well.
And how I utilize block grant monies, how we did that in California. Remember, I was at a substance abuse treatment facility and working with the women. They were all in treatment. They all had an HIV or AIDS diagnosis. However, the children were negative, and I was working with the children and their families, actually. And so in working with the whole family, and not only that, the clients, the women themselves, as I tell people as a nurse, those in treatment are the greatest need for prevention. They need prevention. And so we utilize dollars, and what we did is incorporated prevention curriculum into the curriculum. Imagine someone who's diagnosed with HIV but still doesn't understand what it is. They're diagnosed and say you have gonorrhea, but they really don't understand, what it is, how I got it, etc. So we incorporated that was part of, as I talked about, that comprehensive plan. So prevention is a part of that comprehensive plan. And when you make it a part of the plan, and when you have someone who is licensed, like a licensed social worker or therapist who signs off on that plan, you have a legitimate plan. And I won't get into billing, that's a whole nother topic. But you have a plan at that point to where that's how you incorporate it using block grant dollars into everyday programming.
Thank you. Thank you, guys. I've got some responses that you guys have done a great job by everyone, and they really appreciate the knowledge on the information that you guys are sharing.
Thank you. I appreciate that.
I keep getting thank you, well done. I do have a comment here. It's important to identify primary prevention providers, secondary, tertiary prevention providers in order to deliver effective strategies. Again, great job. So thank you, guys. We really appreciate it.
Yes, I just want to comment on that piece. That is also why it's important to have collaborative partnerships in your own jurisdiction. You guys can get together and create a resource guide on who's offering condom distribution, who's doing testing, who's doing treatment, who's offering needle exchange, who's offering substance abuse counseling or other services, so that you guys can put together a comprehensive list and guide and use that not only in your own organizations, but to disseminate that to community members as well.
That's correct. That's a gap resource analysis, and that really fits really well, Ricardo, in helping communities build capacity, so you know what's already going on, what's not going on, and then have those resources available online, digitally, or as well as in hard copy.
And sometimes you also want to engage the population that you're serving. And why do I say that? Whether it's the LGBTQ population, whether it's the youth or young adult population or seniors, curriculums you're going to run into in the field when you're looking at prevention education, a lot of things may not be culturally competent to the population that you're serving, or you're going to find it does not completely fit. And so it's okay to make some changes. We call it adaptations and fidelity. Yeah. As long as you maintain the fidelity, which is a core component of curriculums, it's okay to make changes, to customize it, to fit the population that you are serving. Okay. Anything else in that chat box, Miss Amanda?
That wraps it up.
Thank you so kindly.
What we want to do is start with Ricardo and close out. Last statements on your end, Ricardo.
Yes. Yes. Again, thank you all for allowing me to lead you today and to evoke some thought, hopefully, and to learn something and to affirm what it is that you do know. Again, we are all in this together, and it takes a community. And so keep doing the good work. And if you need any assistance, we are here to assist.
Thank you, Ricardo.
Yes. And again, thank you, participants, for allowing us and giving us the opportunity to work with you today. Thank you for the engagement. And once again, all of you are in my hearts and in my prayers as we face this COVID-19. So everyone, please stay safe, and stay safe. Thank you so kindly.
And then finally, I want to end with thanking you all for your undying attention. It's very, very unique, you all in North Carolina. We really appreciate it. We appreciate your wanting to listen and learn even during these challenging times. I want to thank you, Amanda, and the North Carolina Training and Technical Assistance Center, led by Jamie Edwards.
Thank you, Jamie.
We thank you all for this opportunity to bring this information, and we hope in the future we can bring other types of information as well. Thank you very much.
Yes, we really appreciate you guys. This has been good to, again, I say get back to a sense of normalcy within the chaos to sit down and do a webinar that was already on the schedule. So it's kind of nice.
Right.
Yes.
Right.
We will post these, the PowerPoints will be posted on our help desk along with the links that Ricardo mentioned. I want to remind you guys that the link for the survey will be sent out within 24 hours. So if you can complete that, that would be wonderful. And we're also going to try and get certificates out to you within the next week. So be looking on for those. If you have questions in the meantime, don't hesitate to reach out to us. If there's something you think of later that you wanted to ask Tracy, Raylette, or Ricardo, reach out to us and we'll make sure we get your questions answered. But thank you all for participating, for your questions. We appreciate it. Until next time.